Okay. I guess since it's one, I can start. So I'm Rae. Today I'll be presenting Journal Club. Um, I do have a few questions in between some of the slides here. And it'll have like a QR code that you can just scan with your phone and then answer the question. And I think then on your phone you'll be able to see the results, but let me know if that is not working right. Okay. So today we'll be talking about this article called The Use of Percutaneous Cystostomy Tube as an Adjunctive Treatment Option for Dogs with Idiopathic Functional Outflow Tract Obstruction. This was published in DACVIM in December of 2024. But first, I thought it might be beneficial to just go through a little bit of background. So pulling from the ACVNU consensus statement on the diagnosis and management of urinary incontinence in dogs. I stole these images from the consensus statement, but just going into a little bit of background, the bladder will have collagen that will influence the structural properties, and then muscle, which will be responsible for the contractile activity. And then the urethra will have an internal urethral sphincter that's smooth muscle, and then our external urethral sphincter, which is the striated muscle. And I thought this photo was really helpful in seeing the difference between female and male dogs, with males having a higher proportion of muscle compared to females. And then I also stole this image from the consensus statement because it was helpful as well, just to briefly go over lower urinary tract innervation. So we have our pudendal nerve that will, tighten the urethra to allow for filling, and our pelvic nerve that is parasympathetically driven, so allows for voiding, contraction of the detrusor muscle, and then urethral relaxation. And then our hypogastric nerve that is sympathetically driven, so allows for relaxation of the bladder muscle to allow for storage of urine. And then they kind of break it down into storage versus voiding disorders. So we won't go into all of that today, since that's not the article we're looking at, but just a brief breakdown of voiding disorders, talking about functional versus mechanical, and there's a long list of mechanical causes for disorders with voiding, and then a much shorter list for functional that are not neurologic in origin, with functional being defined as the inability to pass urine from the bladder to the external environment because the bladder fails to effectively contract, the urethra fails to relax, or a combination of both. And then this can lead to secondary overflow urinary incontinence. So that's just a brief overview from the consensus statement, and then I thought it'd be beneficial just to briefly go through two papers that were retrospectives looking at idiopathic functional outflow tract obstruction in dogs. So this paper, titled Detrusor Urethral Dyssynergia in Dogs, 35 Cases, was published in JSAP in 2021. And just brief takeaways from the paper, their findings. So it was a retrospective study from 2007 to 2019. They excluded any dogs that had any sort of structural abnormalities or neurologic disorders. And so they had 35 dogs included that had suspected detrusor dyssynergia. They had 31 of those dogs, so by far the majority were male, and found that the most common were middle-aged, large breed, largely neutered dogs for their response to therapy. 60% had a good response, 20% had a partial response, and 20% had a poor response. And overall, for medications, they had 55% of cases that had discontinuation of all of their meds, with 10% of those cases having evidence of relapse of their signs. They described that 95% of their cases used an alpha antagonist, and then about 50% of their cases used a skeletal muscle relaxer. For surgical intervention, they did have 2 dogs in this study that had a cystostomy tube placed. One of those dogs did have some hematuria, and the other had UTIs, and then a piece of the tube broke off at removal that then needed to be removed. And so this is our first question, just to spark some discussion, hopefully. If you scan the QR code, you should see the question and then be able to answer it. So how many of your idiopathic functional outflow obstruction cases have you been able to fully taper off of medications? And then I think if I press show results, I think you should be able to see them. Can you guys see those results now?
Yep, we can see them.
Okay, great. So looks like most people, 83%, say 0 to 25%, and then there are some lucky people or a lucky person who has had 75 to 100% tapered off all medications. I haven't had that. I've maybe had like 6 or 7 cases so far, but some of those were like when I was a student or an intern, so I didn't really have any follow-up on them. But I've felt like whenever I've seen these cases, they've always like been on meds long term or had like relapses, even if they were like many months later. So I was just curious to see what other people are seeing. If anyone wants to comment or not, I can move on. Okay.
I agree. I always feel so lucky that they responded to the medication that I'm very reluctant to try and stop it.
Yeah. Okay.
I think that that's because they're coming to us so late. Like, do you think we feel lucky because they've just been messed around with in other places and it's been going on without proper management, and then we get them controlled and then we keep them on it forever? Or how many of these cases are we getting early enough where we feel maybe more confident because they've responded to us doing first line management? I think so many of these cases end up getting treated for UTIs and then another UTI and then another UTI, and just such prolonged mismanagement before they come to us. I wonder if we saw them in the beginning and we got them controlled, if we'd be more confident to actually taper their meds.
Yeah, maybe. I do feel like the cases I've seen, it's been like years that they've been on some sort of meds, and then we like optimize them, and then, you know, the owner's been through so much they would never want to stop the meds. Okay, and then this paper, I wanted to just again touch on the like main takeaways. Idiopathic functional urinary outflow tract obstruction in dogs, a retrospective case series from 2010 to 2021. This was published in DACVIM in 2023. And they had a similar amount of dogs as the previous. They had 31 total, and 29 of those were male. Most of those were neutered. There were 5 intact males, and then there were 2 spayed females. On average, they were 6.9 years of age, so a little bit like middle-aged. And their clinical signs, all of them had stranguria, with almost 50% showing overflow incontinence. And they did have a group, 26%, that had neurologic deficits on their exam. For their medical therapies, they used alpha antagonists, skeletal muscle relaxants, botanical anti-inflammatories, and then other therapies that they described included intermittent catheterization, either at the vet hospital or at home, an indwelling red rubber catheter in a few cases, and then some of the dogs were castrated. There were 3 dogs that were euthanized in this retrospective due to persistent signs, and they didn't find any difference in the medications that were used between those that responded and those that didn't. They did describe 39% of the dogs that had complete resolution of their clinical signs with management, and they didn't describe the use of any cystostomy tubes in this paper or stenting or anything like that. So then our next question. Hopefully you guys can see it. It's asking what medication you typically reach for first. So alpha antagonist or an alpha antagonist and diazepam, just diazepam, botanical, alpha antagonist and botanical. I tried to include different options and then I can show the results. It looks like a split on alpha antagonist or alpha antagonist with diazepam, and maybe one person just starting with diazepam. Anyone want to comment on that at all? No. Okay. We can move to the next question. Let me just stop that poll and then open this one. This one's just asking about if you prefer prazosin over tamsulosin or tamsulosin over prazosin. I feel like I have heard different things from different people, and was wondering if anyone wanted to share what they prefer to do and why.
I'll comment.
Go
I
ahead.
usually use prazosin first, and I phenoxybenzamine used to be on the list too, but it was always very expensive, so we would go with prazosin and the tamsulosin. I think I've been using it more for urethral relaxation than urethral, but it would be a good idea.
Yeah, I tend to use tamsulosin first. Many of these dogs are larger, so you can usually get away with the human tablets for dosing, and it's a pretty safe drug, and there's a big margin of safety with it, so we can really kind of push the dose to see if you can get more of an effect. So I don't really know of any studies or anything that's compared it, but that's what I end up going to because you probably have a bit less risk of hypotension, even though I can't say I've ever seen that with prazosin anyways, but it's a bit more specific. So that's why I tend to use tamsulosin.
Great. I feel like I had one bad experience with tamsulosin and I don't even know if it was related, and then it scared me, but that's not for any good reason. Okay, now that we've done a little bit of review, we'll get to the article of the day. So use of percutaneous cystostomy tube as an adjunctive treatment option for dogs with idiopathic functional outflow tract obstruction. Looked at cases from August 2012 to September 2021. And so in their introduction, they talk a lot about what we kind of just went through. They discuss that signalment is most common in young to middle-aged, large to giant breed dogs, which I think we've probably all seen clinically, and most commonly they are male. They do talk about the terminology, trying to use idiopathic functional outflow tract obstruction as the newer name based off the consensus statement, as compared to older names used like detrusor, urethral dyssynergia, or reflex dyssynergia. So I'll try to use that terminology in the rest of today's journal club. and then making a diagnosis by ruling out causes of mechanical outflow tract obstruction that could lead to a large post-void residual volume. And then they discuss kind of medical management with alpha antagonist and skeletal muscle relaxant, plus or minus a parasympathomimetic, anti-inflammatories, or anti-anxiety medications. And then they discuss other reported interventions like the at-home intermittent urinary catheterization or an indwelling red rubber catheter, urethral stenting, balloon dilation, or cystostomy tubes. And so to talk just briefly about cystostomy tubes, they did bring up a larger retrospective from 2007 that looked at cystostomy tubes in dogs but didn't include any cases that had idiopathic functional outflow tract obstruction. And they just discussed the benefits for drainage of urine without causing any trauma to the urethra, and trying to utilize these tubes as a temporary method while medical management is started, and then keeping the bladder small to try to avoid any secondary detrusor or atony, and keeping these dogs home and out of the hospital if we can with the tube in place, so they don't have to be hospitalized and catheterized if owners can't do that at home. For their case selection, so their inclusion criteria, they had clinical signs consistent with idiopathic functional outflow tract obstruction that included stranguria or dysuria. They had to have a lack of any structural abnormalities on imaging. So all of these dogs had radiographs or ultrasound performed, and then they either had a scope performed or a contrast study done. And then they were excluded if they had any abnormalities that were causing a mechanical outflow tract obstruction, so stricture stones, proliferative urethritis, a mass, etc. And then they also had to have a normal neurologic exam to be included. They were allowed to have a UTI present or being started on antibiotics as long as that didn't fully resolve their clinical signs. And then they needed to have a minimum of 30 days of follow-up. So here's the figure from the paper. It just kind of shows the cystostomy tube placement. They discussed that all tubes were placed percutaneously except for one of them that was placed surgically. All of the dogs underwent general anesthesia for placement. The bladder was isolated and the catheter was inserted with a contrast cystogram performed, and then the guide wire advanced and the pigtail catheter advanced into the bladder and then sutured to the body wall, and then appropriate placement was confirmed with fluoroscopy. And that's just shown there in the figure from the paper. And then for outcomes, they described refractory or dogs being refractory to treatment if they had a poor response to appropriate medical therapies for at least 1 week that resulted in recurrent episodes of outflow tract obstruction or exclusive use of their cystostomy tube or consideration for euthanasia. And they defined appropriate medical management as the animal being on an alpha antagonist and a skeletal muscle relaxant at appropriate doses based off of the consensus statement for at least 1 week. And so then we have our two tables from the paper. Table 1 shows kind of the grading system for outcome scores. So if they had an excellent outcome, that meant that their signs resolved and they didn't have any need for medications, and they didn't need to use their tube or be catheterized. If they had a good outcome, that meant their signs resolved and they might have flare-ups that were managed with medication, but they didn't need catheterization and they had their cystostomy tube removed or didn't need to use it. And then fair outcomes had resolution of signs with medical management, but they did have intermittent obstructions where they needed catheterized or they needed to use their cystostomy tube. And even dogs that use their cystostomy tube exclusively, they were placed in that fair outcome category. And then a poor outcome, those dogs were unable to urinate normally, they needed catheterization, or they had severe complications related to their tube that either resulted in euthanasia or death, or quality of life concerns. And then we have table 2 that discussed tube complications. So there were mild complications if there was any issue with like a loose suture or inflammation of the stoma site or leakage. There were classified as a moderate complication if they broke the tube or removed it and needed the tube to be exchanged or had chronic infections, and then severe if there was removal that necessitated like immediate need to replace the tube, or they had like a uroabdomen or something like that. For their results, they had 16 male dogs that met the inclusion criteria, but 4 of those did not have follow-up, so they were excluded. So overall, we were looking at 12 male dogs. 6 of them were intact and 6 were neutered. And then of the intact male dogs, 5 of those were subsequently neutered. 8 out of the 12 had a contrast study performed, 2 of which had normal narrowing of the pelvic urethra. And then 7 out of the 12 had a scope performed, with some of them showing erythema of the bladder wall or fibrinous strands in the urethra suspected to be from trauma from catheterization, or lesions that looked like friction across the urethral folds. Their age range was 1 year to 11 and a half years, and most of the dogs had blood work performed, 10 out of 12. None of which showed azotemia. The most common abnormality was a high AST and high CK that was seen in 40% of the cases. And then 7 out of the 10 dogs had pyuria, with 1 out of those 10 that had a UA done showing bacteria. And then 2 dogs did have a positive urine culture with Pseudomonas or E. coli. And I know they talked about quite a few of the dogs being put on antibiotics even when they didn't have a positive culture or bacteria. And then there was nothing of significance really found on ultrasound or radiographs in the cases that did have those performed. For management, 11 out of 12 dogs were originally medically managed, with 6 of them being put on tamsulosin, 5 on prazosin, 2 on diazepam, and 2 on bethanechol. Other management that then we'll talk about a little bit more, 7 of the dogs did have a cystostomy tube placed, and like I mentioned earlier, 5 of the intact dogs were neutered. For the dogs refractory to medical management, they classified 8 out of the 12 as refractory, of which 5 of those did have a cystostomy tube placed. And then for the other 3 that didn't, 2 continued on with medical management, and 1 had intermittent catheterization at home. Of the 4 dogs that were not classified as refractory, 2 did have a cystostomy tube placed, and then 2 were medically managed. And so for the dogs with cystostomy tubes, again, 7 of them had the tubes placed, 5 were classified as refractory, with 3 dogs classified as refractory before placement, and then 4 dogs had the tube placed before they had maxed out their medical management, of which 2 responded to medical management. For 5 out of the 7 dogs that did achieve complete disuse of their cystostomy tube, in 2 of those that occurred within 1 to 2 weeks. In 1, it occurred in 3 to 4 weeks, and then 2 occurred greater than 4 weeks. There were 15 tubes placed total, so that averages out to about 2.14 per dog. But there was 1 dog who had 5 placed, so he definitely drove up that average. And 14 out of the 15 were placed percutaneously, but that 1 dog that had 5 tubes, 1 of those was placed surgically. For removal, 33% of the time they were removed by the clinician due to improvement and feeling like they didn't need the tube anymore. 33% of the time the dog felt like they didn't need the tube anymore and they removed it and it didn't need to be replaced. And then 27% of the time, the dog removed it and it did need immediate replacement. So that would fall in that severe complication for that we talked about earlier with table 2. And then one was removed by a dog but was not replaced due to euthanasia. For outcomes, out of the 12 dogs, 10 of them did improve, with most of them improving within the first 1 to 2 weeks, and then some showing improvement later after 4 weeks. 2 dogs did not show improvement, and one of those did have a tube placed. The other did not. And then of the dogs that had a cystostomy tube placed, 71% fell into that excellent outcome group. So that means they 71% of them were no longer utilizing their tubes at all. 8 out of the 12 were refractory to medical management. 5 of those with a tube placed, and of those 3, so 60%, had a good or excellent response. And that good category also, they weren't utilizing the cystostomy tube anymore. But none of the 3 without a tube placed had a good or excellent outcome. And then for follow-up, only 1 dog in the study was euthanized for reasons related to their idiopathic functional outflow obstruction. This dog did have a tube placed that was removed. And then 1 dog that did have a tube placed and then was removed, they had recurrence of urinary obstruction 180 days after the tube was removed. I kind of wondered how long they had waited until removing the tube, or maybe this was one of the cases that the dog removed the tube, and since they weren't utilizing it, they didn't replace it. And then they talk about 80% of the dogs medically managed had recurrence of urinary obstruction, which I feel like seems to fit more with what I see. If I had a dog with a tube in place, I'd just be worried that they would flare a few months later and then we'd regret taking it out. The follow-up time was a little bit different as well. Dogs with tubes were followed on average for 323 days, and dogs without had an average follow-up time of about 128 days. So is it possible some of those medically managed dogs without tubes had less recurrence, as they got further out? I'm not sure. As for complications, all of the dogs that had tubes placed did have complications. They all had mild complications, so either like a loose suture or leaking around the stoma or inflammation. 71% had moderate complications, so inadvertent tube removal that didn't need replaced, or chronic urinary tract infections. And then 71% did have more severe complications, so they removed the tube where they did need to immediately replace the tube, or they had leakage of urine around the tube that led to a uroabdomen. So I think for the takeaways from the paper, cystostomy tubes certainly can help dogs get out of the hospital, since owners are then able to more easily empty their bladder at home. But owners need to be aware that complications will happen. They might be mild or they might be more severe, and they need to be prepared for that and to watch the dog closely. And that a cystostomy tube can be utilized to allow time for medical management to work, or even if an owner is not comfortable catheterizing their dog at home, then would this be an option to keep them from constantly coming back into the hospital if they are obstructing at home? And then we have another question. This question is just, how many of your idiopathic functional outflow obstruction cases have you placed a cystostomy tube in? So it looks like most people are answering none, and then maybe one person answered very few, and one person answered some. Does the person who answered some want to share?
I can share, sure. In my experience, it is mixed for those patients that have had to have tubes. I guess maybe I've been more lucky because I've had medical management be successful in a handful of cases. And that certainly could be biased just where I'm remembering those that have done well. But then if I think about the number of tubes that we've placed, there's not 1,000 of those compared to these cases that we see. So I think with medical management and catheterization, you are often able to get some improvement. I think the patients who come to us with either inappropriate management so far, maybe one drug, and they're a male dog that the owners can easily catheterize, I've been fairly successful in optimizing their therapy, having them continue to catheterize for a short term, and then being able to not catheterize them as the meds are kicking in. If they're still having difficulties, then certainly that's when we're going to place a percutaneous tube. But there are those patients that come to us that have already been on everything and have already had catheterization for a long period of time and have decent management. Those patients are probably going to be a bit more aggressive and place the tube in sooner. So I think there's a bit of a spectrum. Those patients that haven't had much management, I don't think I would jump to placing a tube on right away, especially if they could empty their bladder reasonably well, or if they were easy to catheterize. But I do worry about the risk of catheterization causing persistent stimulation of the urethra. So I don't know if there's a really like best case scenario in terms of how to manage these patients because they come with a bunch of different backgrounds. But I have had a fair number that we haven't had to place percutaneous cystostomy tubes in, or a permanent tube for sure.
Has anyone else done any other procedures? Like I know sometimes people bring up like ballooning or stenting. Has anyone had any?
I guess I would also echo JD's experience. Most of the time, I'm able to manage them with medical management and intermittent catheterizations, probably over the, I don't want to say how many years, but multiple decades. I've probably only had to rely on percutaneous cystotomy tubes and maybe 3 or 4 male dogs, and one is a wolfhound who was just too large for the owner to manually extrude and pass a catheter. It was the only, it required a very long catheter to reach him, his bladder. And my record, I think, is like 5 or 6 years in a lab that lived to be 16 that came to me having failed medical management and other management, had like a fractured urethral stent in. He had been pexied a number of times. And we just trade, and he was, a nightmare in terms of recurrent either basachuria or active infections. But his percutaneous tube was in so long that his stoma kept stretching out. And we ended up, ultimately going from a low profile to a just a large Foley catheter that was horse size. We traded his catheter out about every 3 or 4 months to keep the biofilm low on him and not really have anything more than basachuria and not active infection.
Anyone else have any experience they want to share? No, okay. And then lastly, I just wanted to briefly talk about this paper, single step, non-surgical placement of permanent low profile cystostomy tubes in dogs, 10 cases. from 2018 to 2023. Just briefly, their findings, they had 10 dogs, 8 of which they were able to successfully place a low profile tube non-surgically. 2 cases weren't able to be done because the bladder was moving away from the body wall, and then there was free fluid, and so they had to go to surgery to place the low profile tube. Most of the dogs, so 7 out of 8, did need replacement, mean time of 103 days, so maybe not as permanent as we hope. And then, but 82% of the time is successful replacement just through the existing stoma. And 2 dogs had that occur within the first 14 days, and they didn't develop a uroabdomen, which is great to know. And then they just talk about how the low profile tube might be more ideal because it's less bulky and less likely to be inadvertently removed. And they did this in a range of dog sizes. So 6.9 kgs was their smallest, and then their largest was 36.4 kgs. And 40% of these cases were having the tube placed because of idiopathic functional outflow obstruction. And then in dogs that did have inadvertent removal that did not need replacement, the stoma just healed on its own in 3 to 5 days. And 1 dog had some leakage at the stoma site that resolved. And so they also talk about in this paper just how the low profile tube is convenient, and it would be even more convenient if it can be placed without surgery to avoid cost and further hospitalization charges. And then here I just kind of typed out the methods that they went through and how they placed the tube, but I won't go into that right now. In their tube size, they said they used 1.5 centimeter for dogs that were less than 10 kgs, and then 3 centimeter in dogs that were greater than 15 kilograms. So then my last question, oops, okay, I think it should be open now. Has anyone here ever placed a low profile cystostomy tube non-surgically? And it seems like either only one person has answered or everyone is saying no. Oh, 7 people have answered. Great. So no one has done that.
Oh. Would you, Rae? Would you place the low profile tube percutaneously?
Not without practicing on some dead animals first.
Okay. Do you have any concerns for the low profile one compared to the traditional drainage catheter? Is there any other reasons other than just lack of attempts that you would want to choose one over another?
I think, well, we recently considered this in my case of a cat, and for him mostly was just, I guess, how likely I think the patient is to pull it out. I think they're less likely to remove the low profile. So if they're really wild, would that be better to go to? But it also seems like both of these had a significant amount of like inadvertently removed tubes. So I don't know if that actually is a good reason to consider the low profile.
Yeah, I think the surgically placed ones, it depends upon what your surgeons are going to do, if it's going to be beneficial. If they're just going to do a cystotomy and place it and then sew everything up, then the percutaneous method's probably not inferior. But if the surgeons do a cystopexy as part of their tube placement, and you end up getting this track going from the skin into the bladder, then you have the ability to continue to swap the tube out and replace it if it becomes gross with a biofilm, as Mary had suggested, or if there is just wear and tear of the plastic and it starts to degrade. With just the regular percutaneous placement, both the low profile and the traditional drainage catheters, if they come out, you kind of have to start all over from scratch. So you don't have that tacking. So I'm interested to see if anyone in rounds who sent a patient for a surgical cystostomy tube, did their surgeons perform a cystopexy as part of it or not? Your last patient, Ray, they did pexy it as part of it. Is that right?
I believe so.
Or maybe no one sent patients for a surgical cystostomy tube before.
I'm trying to think. I think some of my surgeons have pexied, and a couple I asked them to not pexy. But the majority have pexied have done a pexy.
Yeah, I mean, there's certainly some problems to consider with the pexy that you could have adhesions. If they place it in a weird position or if they put traction on the bladder, then that could be problematic. But generally, it's well tolerated, especially if it means that the tube is going to stay in for a longer period of time.
That's all I have. Any other comments anyone wants to make? Okay.
No, that was great, Ray. Thanks so much.
Okay, thanks.
Thank you.